Hey there, this is Dr. Stanwood, and today we are talking about hyperthyroidism. As you know, endocrine's my specialty, so you are going to find that I might give you more information than you need for primary care, but hopefully it will help you along the way. When you're concerned about hyperthyroidism, you want to check thyroid function in any of your patients who are complaining of abnormal weight loss, tachycardia, shortness of breath, anxiety, nervousness, insomnia, diarrhea. Certainly, if you have a patient coming in with exophthalmos that looks concerned with no other reason, fatigue, you can see menstrual irregularities. I do it as part of my annual screening in my diabetics because especially in my type 1s, because if you have one autoimmune disorder, you're more susceptible to the others. And then we also see some medications that can impact thyroid function. And a very common one is amiodarone, or a lot of our cancer patients are on checkpoint inhibitors, and the oncologists are really good about checking thyroid function in those patients. Amiodarone is unique because the thyroid gland is the only gland in the body that takes up iodine. And what happens is amiodarone has a ton of iodine in it. And in somebody with like an underlying autoimmune disorder, oftentimes the amiodarone will be taken up by the thyroid and cause thyroid dysfunction. What do you order? If you are concerned about hyperthyroidism, always check a TSH. If the suspicion is really high, add on a T4, a free T4 and a total T3. The free T3s are expensive and you can get just as much information out of a total. In most cases, just get your TSH first. And then if you need a repeat it with the free T4 and the total T3. So you're not spending that money unless you know the TSH is abnormal. And then as I tend to teach is do not order a thyroid ultrasound just because somebody is hyperthyroid. I see primary care providers do this, and it is a thyroid ultrasound is indicated if you feel a palpable nodule, patients having local symptoms, or we may order it in hyperthyroidism in certain situations, but I would leave that ultrasound up to the endocrinologist unless you have concern about a thyroid nodule. Like imaging says that, go ahead, order it. Physical exam. You may see a goiter, you may feel a goiter, or you may feel nodules. In some cases of severe hyperthyroidism, you can hear a bruit over the thyroid. We talked about the exophthalmos that may be subtle, or the tachycardia. Reflexes are we talk about hyperreflexia. What you're going to notice is just a rapid reflex. So it's not as much a strong reflex as it's fast. That's the best way I can describe it. And you might have a painful thyroid. I have honestly never seen this. It is very concerning for infection and it rarely occurs. But if somebody's got a really painful thyroid, like warm to the touch, that sort of stuff, send them to the ER. Okay, the first thing you want to do in hyperthyroidism is you want to say to yourself, do my labs make sense? TSH can be low when a pituitary is not working. Remember, pituitary stimulates the thyroid to make thyroid hormone. If the pituitary is not working, your TSH could be low because the person has a pituitary tumor. The way that you know your pituitary is appropriate in hyperthyroidism is that you get a free T4 level. I said in another hypothyroid talk that you don't need to get a free T4 in hypothyroidism. And the reason why is because if you've got a pituitary making a lot of TSH, it's probably working. You don't have to worry about under-functioning pituitary. If your TSH is, and then you kind of want to look at your axis. So if your TSH is low and your free hormones are low, that is an inappropriate response and something's going on up here. If your TSH is low and your free hormones are high, that's an appropriate response, and that's pretty standard hyperthyroidism. Okay, so I put this in here just to remind you the pituitary makes TSH, and then the response to the thyroid hormone feeds back to the pituitary, and that's what we refer to as the axes. In endocrine, you'll hear pituitary axis, adrenal axis. female hormone axis, gonadotropin, stuff like that. If your axis is intact, you're going to determine, is this acute hyperthyroidism or subclinical? Subclinical is the same as it is for thyroid. You've got, except for this one, or hypothyroidism, I mean, in this one, you've got a low TSH, but your free hormones are normal. So subclinical is basically saying you've got free hormone levels, so it's compensating, and it's compensating well. In acute, or I'm trying to think of the acute hyperthyroidism, you're going to see a low TSH and your free hormones are going to be elevated. The degree of the hormone elevation typically coincides with the degree of the hyperthyroidism. It's not always the TSH that kind of tells you how hyperthyroid they are. I put in here one of my up-to-date flow sheets because I love them. And, essentially, is the patient pregnant? That's the first thing you want to say. So let's say it's no. Is the patient taking biotin? The reason why we ask about biotin is that the TSH assay is biotinylated, which means that biotin can interfere with it. So if somebody is taking biotin for hair growth, you want to make sure that they stop it for 2 to 3 days and then get that biotin out of their system, repeat the TSH. I have seen patients that I've consulted for hyperthyroidism, and when I stopped their biotin, their levels were normal. If the T3 is elevated, then you've typically got more of a subclinical. Now, I would say if the T3 or the T4, there's the possibility that if the T3 is elevated, you've got T3 toxicosis. And that just means that the T3 is more predominant than the T4 in determining the toxicosis. And then you're going to refer them to endocrine. I would honestly refer any of them to endocrine just in the beginning, because you don't really know as primary care providers how to manage this. And so I think it's a good idea to do a couple referrals and then get a sense of who you should refer after that. So indications for treatment in subclinical hyperthyroidism. If you've got patients whose TSHs are above 0.1, I always use 0.1 as kind of my marker for treatment. If their TSH is below 0.1, then that is somebody that's going to be treated. If their TSH is low, but it's above 0.1, if they don't have cardiovascular disease or osteoporosis, then oftentimes you can just observe. If they do have cardiovascular disease or osteoporosis, then oftentimes we will treat. So if you've got somebody with a TSH of 0.3, they're fine, they're not having any problems, you can just monitor that as long as they're not symptomatic. You can also send them to endocrine for a one-time visit to double check some things, but that's not something I would worry about too much. What are the causes of hyperthyroidism? I go through this with my patients. So we've got Graves' disease, toxic nodules, thyroiditis, and medications. Essentially, Graves' disease is where the entire thyroid gland is spitting out too much thyroid hormone. It is autoimmune and it needs to be treated. A toxic nodule is typically where the patient's got a nodule on their thyroid and that nodule has a life of its own and then just spitting out a bunch of thyroid hormone. Typically, we see higher levels of thyroid function in Graves' disease versus a toxic nodule because the entire gland spitting out a bunch of hormone tends to cause higher levels. You may see a thyroiditis. A thyroiditis is a temporary inflammation of the gland. We most commonly see this postpartum. So a woman has a baby and for whatever reason, the hormone changes affect her thyroid. She spits out a bunch of thyroid hormone, goes to see her primary care provider. They see a low TSH, send them to endocrine. We recheck the TSH and it's now high. So what's happened is they've developed this transient low TSH followed by a high. And then in most cases, a thyroiditis will recover to normal with no treatment. In about 20% of people, there's been enough damage to the thyroid gland that they develop a permanent hypothyroidism. So in thyroiditis, you're just going to follow the trends and see what happens. And sometimes a thyroiditis can take about 6 months to fully recover. I bring up our amiodarone and thyroid hormone because I have had a couple of cases of consults where the patient was hyperthyroid and they were on thyroid hormone. Obviously, if they're on thyroid hormone, decrease the dose. If they're on amiodarone and they can't get off it, refer them to endocrine. If they can get off it, it can take over a year, up to 2 years, to see the effect of amiodarone, the iodine, leave the body and render the thyroid back to normal. Those really should be managed by an endocrinologist. In hyperthyroidism, this is the part that I'm probably giving you more than you need, but I honestly think it's helpful for conversational purposes. If you've got somebody with hyperthyroidism, in the old days, we did a thyroid scan with uptake on everybody. Now we really resort more to this thyroid stimulating immunoglobulin. And the reason why is because some of the treatments that we're doing with thyroid, with Graves' disease or hyperthyroidism, we don't really need the information we get from a thyroid scan with uptake. A thyroid scan with uptake is essentially looking at the thyroid and seeing how it takes up iodine. So if you recall, I said that the thyroid is the only gland in the body that takes up iodine. And what happens is we get a pattern of uptake. So they go in, they swallow a pill of iodine, they come back 6 to 24 hours later, and they get a scan of their thyroid. And then that scan gives pictures, and it tells us how the thyroid took up the iodine. So for instance, did the entire thyroid take up the iodine? Do we just see the iodine being taken up in like a nodule? So we know that there might be a nodule in the thyroid, different things like that. The thyroid stimulating immunoglobulin, if it's positive, this is just a lab that you order. If it's positive, it is very consistent with Graves' disease. If I've got somebody who has hyperthyroidism on their labs and a positive TSI, it is pretty much Graves' disease. So this antibody allows the release of thyroid hormones independent of pituitary TSH, and it's almost positive in Graves. Some people use the thyroid receptor antibody, which can be interpreted in the same way. This is what your thyroid scan with uptake is going to look like. This person took iodine, and then the iodine got taken up by the thyroid, and you can see the thyroid is this butterfly-shaped gland. And a cold nodule is essentially where the thyroid took up the iodine and then it just stopped at that nodule, like it couldn't get through the nodule. Cold nodules are more concerning for cancer. In Graves' disease, we tend to see this really consistent uptake of iodine throughout the whole gland. The pyramidal lobe, sometimes when they're really hyperthyroidism, the pyramidal lobe is kind of the classic sign of Graves' disease because this is the lobe it's kind of like the root to your thyroid gland, where when you were just born and your thyroid was developing, or in utero when your thyroid was developing, your thyroid came from the pyramidal lobe. And so sometimes you can see that in imaging. Hot and cold nodules, you could have a thyroid that has both. A hot nodule is something where oftentimes that nodule takes up all of the iodine, and then the rest of the gland has kind of gone to sleep because the nodule's doing the rest. If you have a fully autonomous nodule, you won't even see the rest of the gland. And then a thyroiditis, like we talked about with pregnancy, in that situation, you may not see any uptake at all, and that can be diagnostic for thyroiditis, or if they're on something that's blocking your scan. How do we treat Graves' disease? We use a lot of anti-thyroid drugs. In the old days, we used to use them for 1 year, and now studies have shown that we can use them long-term. In my younger people, I do recommend radioiodine ablation, which we'll talk about, but anti-thyroid drugs, sometimes we can put patients on them, and 30% of the time it induces a remission, and they might have normal thyroid levels after a year or two. It is nice if you've got somebody who urgently needs to get their levels lower. It normalizes your free T4 pretty quickly. We've got methimazole and PTU. Methimazole is the one we use pretty regularly. PTU, I used it for years with this endocrinologist. He really liked it. The doses, it requires more pills and it can cause neutropenia and elevated liver function. I don't see that at all. In methimazole, you might see a rash, and rare cases, the neutropenia can be caused by both of the drugs. So if somebody's developed signs of recurrent infections, things like that, you would want to review that. Radioiodine ablation is the gold standard in the treatment of Graves' disease. What it is when we talked about the thyroid being the only gland in the body that takes up iodine, we give them a bigger dose of iodine and have them swallow it, and it gets taken up by the thyroid and kills it. And then over the course of 6 weeks to 6 months, that thyroid kind of fails. And then we put them on thyroid hormone. Surgery is only used in cases of intolerance or failed ablation, or if they've got a huge goiter or they're just intolerant of some of the medications. Treatment of toxic nodules, ablation is the gold standard. So we give them that dose of radioactive iodine. It gets taken up by that overactive nodule and kills it, and then hopefully leaves the rest of the gland normal. But in many cases, there's still enough iodine that gets into the rest of the gland that they're permanently hypothyroid. If we see a cold nodule on a thyroid scan with uptake, we biopsy that because it's got a higher risk of cancer. We talked about the thyroiditis. This is a little bit more of the pattern I was talking about, where they see one provider, get referred to endocrine, and the levels are very different, and over time it just normalizes. Beta blockade, if you've got a patient who's having a lot of palpitations from their thyroid disease, we typically use metoprolol or atenolol, and that can help with a bunch of the symptoms. If a patient's got thyroid storm, it is an emergency. I rarely see this. There is a point scale. It's called the Birch and Wartofsky scale, where it can tell you if you're really worried about a patient and you think they have thyroid storm, you want to send them to the ER. You basically assign points for each of these issues, and then send them to the ER if they meet criteria. So they have to have a certain amount of points to be positive, as you can see here. All right, so in summary, check a TSH and ensure that your free T4 and total T3 are appropriate. Use a TSI or a thyroid scan with uptake to determine the cause of hyperthyroidism, and then options to treat include antithyroid medications or ablation. Hot nodules are almost never cancer, and cold nodules require a biopsy. All right. I hope you guys got some from that. Now you can be full-blown endocrinologists. You guys have a great week. Take care.